Okay, fine. Good evening, dear students. I welcome you to this session of the INICET type of questions. Myself, Dr. Nitin Kararia, and I shall be discussing some important questions related to the subject of conservative and endodontics. And I sincerely hope that this session would be helpful for you in the forthcoming examinations. So as displayed, if we look at the first question, this is a picture based question, and it is a good thing that majority of the questions and good amount of questions which are coming in the examinations these days are based on the pictures either of the materials or the instruments. So something which is shown visually is becomes easier to understand and answer. So displayed the first question, it talks about identify the material shown in the image, and the second part of the question is what is its clinical indication. So the first part has got two options. Is it a pattern fissure sealant or a resorbable paste? And for the second part of the question, the options listed are: it is used for occlusal caries treatment, it is used for proximal caries treatment, it is used for pulpotomy, or it is used for pulpectomy. As you can see, these are the syringe based materials over there. So they are restorative resins. These substances are basically restorative resins. Okay, and so the option would be it is a pattern fissure sealant and not a resorbable paste. Now what is the clinical indication for this? Occlusal caries treatment, proximal caries, pulpotomy or pulpectomy. We all know that pattern fissure sealants, they are used to arrest and they are used as a preventive measure in the pattern fissures, which are the most probable areas for the development of caries. So these are basically used for occlusal caries treatment, or since looking at the options, all of them are not practically correct because pattern fissure sealants are preventive. They are used to prevent the development of caries in the caries susceptible occlusal pits and fissures. So the best answer is occlusal caries treatment, and they are pattern fissure sealants. Okay, so 1A would be the answer to this question. Coming over to the next question, it is asking you CPP ACP is what? Now you must have read about that these days variety of formulations are available in the market which help in remineralization of the initial carious lesions, and one of the systems which is effective enough is marketed as GC Tooth Mousse. It's a compound called GC Tooth Mousse, and this GC Tooth Mousse basically consists of amorphous calcium phosphate compounds. So this is amorphous calcium phosphate compound, and the options given are: it is used for remineralization system, it is a fluoride based remineralization system, it's a preventive resin restoration, or it is a pattern fissure sealant. So as I have told you, this is something, a formulation which helps in deposition of calcium and phosphate on the initial carious lesions, help in remineralization. So the answer to this question would be it is calcium phosphate based remineralization system. That is A is the answer to this question. And what is GC Tooth Mousse? GC Tooth Mousse is brand name of the product or the paste which is commercially available that contains ACP CPP, and it helps in remineralization of initial carious lesions. Coming over to the next question. Which of the following holds true about Teflon coated instruments? Teflon coated instruments. Teflon is basically a synthetic polymer. And the options given are: it is coated with metal alloy, it is coated with polymer, the instrument made of specific shape and size, or the instrument has been manufactured such that it does not distort. As I have told you, Teflon is basically a synthetic polymer coating. So it is very much obvious what would be the answer to this question. It would be option B, that is, it is coated with a synthetic polymer, polytetrafluoroethylene. Okay, polytetrafluoroethylene is the polymer which is commercially called Teflon. You also know that there are non-stick cookware available in our households and they are commonly coated with Teflon. It is a black color coating. And what is the advantage of this coating on the surface of the instruments? It reduces or eliminates the tackiness or the stickiness with composites. Composites are paste-like materials. So if we are using a non-coated stainless steel instrument, it is likely to stick to the composite. This Teflon helps in preventing. It is a non-stick like of coating. Okay. Coming over to the next question. This question asks you, what is the time gap between the curing and finishing of composites? Okay, curing means basically the light cure polymerization of the composites, and finishing of composites. How much time we should wait? And the options are 5 minutes, 15 minutes, 10 minutes, or 20 minutes. Now there is a standard protocol that once we have finished with the curing of light cure composites, okay, it is best to wait for at least 15 minutes so that the surface becomes hard enough to resist the polymerization finishing of composite. Okay, so the answer would be 15 minutes. It helps in achieving adequate surface hardness. Surface hardness to resist polishing and finishing of composites. And just an added point, what is the agent that we use commonly for the finishing and polishing of composites? The polishing agent for the composites most common is aluminum oxide or alumina, and this aluminum oxide or alumina is used in the form of various cones, disc, etc. Various commercial shapes are available. All are aluminum oxide based finishing materials. Okay, so we move over to the next question. Which factor reduces flow of pit and fissure sealant on occlusal surface of permanent maxillary first molar? Okay, whenever we are applying some pit and fissure sealant, they are flowable composites, basically non-filled or very lightly filled composites. So what factor reduces the flow of pit and fissure sealants? The options given are: is it a Y-shaped fissure, reducing of the viscosity, the presence of cusp of carabali, or occlusal surface is not isolated, cleaned and dried properly? So looking at the options, if we talk about Y-shaped fissure, see, the geometry of the fissure does not influence the penetration of the pit and fissure sealant. Reducing the viscosity, definitely if the viscosity of the pit and fissure sealant is less, it would more readily flow to the bottom of the pit and fissures. The presence of cusp of carabali is of no significance, and occlusal surface, if it is not isolated properly, cleaned and dried, it would definitely hamper the penetration of sealant to the base of the pit and fissures. So the answer to this question would be D. This is the factor which influences the penetration of pit and fissures to the base of the cusps. Okay. Now let us move over to the next question. It is again an image based question, which are common these days in both your NEET examinations and your INICET examinations. The device shown in the given image is used for working length determination, pulp sensibility testing, biomechanical preparation, or pulp vitality testing. So it is a simple straightforward question. You can see that there are readings indicated which indicate something called 00 or like. So reading 00 basically means apex. So it is basically an electronic apex locator that is used for working length determination. Okay, so it is an electronic apex locator. And one of the question which has been asked a number of times in your examinations is, what does the reading 00 on EAL indicate? So EAL basically indicates 00 as apical foramen or the major apical diameter. So reading 00 or apex is indicated for apical foramen, and whenever we are doing root canal, the apex locator measures the distance from the coronal point to the apical foramen, and as a safety factor we have to subtract 0.5 to 1 millimeter for the actual cleaning and shaping and obturation of the root canals. Okay, moving over to the next question. Again an image based question which has got two parts. The first part is asked, identify the pathology highlighted in the arrow with the given radiograph. The tooth has a history of trauma and the tooth is non-vital. What will be the recommended treatment in this case? So firstly, the first part has got two options, whether it is external root resorption or tooth ankylosis. And the second part is, what are the recommended treatment, pulpotomy, calcium hydroxide as a medicament, or what? Now if we look closely at the radiograph given here, you can easily identify that there is shortening of the root of the maxillary central incisor as compared to the adjacent tooth. So it is definitely a case of external inflammatory root resorption. EIR stands for external inflammatory resorption. External inflammatory resorption. Okay, so the first part has the answer, like it is external root resorption and not the tooth ankylosis. And what is the treatment, pulpotomy or calcium hydroxide as a medicament? See, pulpotomy is basically a part of vital pulp therapy. It itself says the question, the tooth is non-vital, so there is no question of pulpotomy. There is no vital pulp to preserve. We would do a pulpectomy procedure, okay, with an intracanal medicament that prevents the resorption. So which is the intracanal medicament indicated over here? It is calcium hydroxide as a medicament. Okay, so the second point would be, it is external root resorption with calcium hydroxide as the medicament. So the answer to the above question would be B. Okay. We move over to the next question. The given image shows radiographs taken for reimplanted teeth number 11 and 21. The two maxillary central incisors have been reimplanted. At the time of trauma and at 12 months follow-up in a 9-year-old child, which of the following is true about the present day condition and prognosis of the two teeth? Okay, there has been a history of trauma with a 9-year-old child. There has been a history of tooth avulsion which have been reimplanted, both the maxillary central incisors. Now you can see this is at the time of trauma, the first radiograph, and this is 1 year follow-up. So what do you see? Here we see that the apex of the tooth is open with a decent amount of PDL widening and periapical pathology evidence. And if we look at the 1 year follow-up radiograph, we can see the root development has continued. Okay, and there is apical closure with resolution of periapical pathology. The bone around the tooth is healthy. So what is this? It is a case of closed apex or good prognosis, open apex or poor prognosis, hypercementosis with good prognosis, and hypercementosis with poor prognosis, as you can clearly identify from the radiograph. Okay, you can see on the second radiograph, it is a case of closed apex with good prognosis. So answer to the above question would be A. If we have to discuss the other options, open apex and poor prognosis, which is not there. Hypercementosis with good prognosis and hypercementosis with poor prognosis. Whenever there would be hypercementosis instead of closed apex, the root length would not increase. Okay, there would be simply bulbous widening of the root apices because of deposition of large amounts of cellular cementum at the apex of the tooth, which is not the case in the radiograph 1 year follow-up shown here. So what does it indicate? It indicates that when at the time of trauma it was an open apex tooth and the tooth was reimplanted immediately, it has led to favorable prognosis with closure of the root apex. Option A is the answer here. Move over to the next question, another image based question. Okay, it says, which of the following is shown in the given image? A rather straightforward question. EPT or electric pulp tester, the caries detection using Diagnodent, curing of composite resin restoration, or sealing. Okay, as you can see, this device is placed on an isolated tooth surface. Okay, so basically this is an electrical pulp tester. So answer to the question would be A. This is not caries detection with Diagnodont, because in caries detection with Diagnodont it has got a fine tip and it is mostly done on the occlusal surfaces. Okay, as you can see, it is done on the facial surface of an anterior tooth, that is maxillary canine, to stimulate the pulpal nerve fibers. So it is basically a pulp sensibility test with electric pulp tester. An electric pulp tester has stimulation of A delta nerve fibers. It stimulates A delta nerve fibers. Okay, we move over to the next question. See, all these questions have been asked recently in your examinations, and I would say that they are rather simple questions. You have to have understanding of the basics of your subject, and image based questions have become a norm these days. For all the subjects, image based questions are coming. So it is very much important that you are thorough with all the important images related to instruments, techniques, devices, materials, and procedures with all the subjects. Okay, the type of traumatic injury shown in image for tooth number 21 is what? Is it concussion, subluxation, intrusive luxation, or lateral luxation? They are asking you about tooth number 21. This tooth they are asking you about. So what type of injury is it? Concussion, subluxation, intrusive, or lateral luxation? What could be the answer to this question? See, whenever there is a subtle form of injury which do not lead to any changes in the tooth structure, simply a little period of paresthesia or altered sensation is there, it is said to be concussion. There is no damage to the tooth vascularity or the nerve fibers. Only there is some altered sensitivity, or that we call paresthesia, for a couple of weeks. Then subluxation, definitely increased mobility of the tooth is there. Okay. Intrusive luxation, definitely the tooth would become shorter in length because it is pushed inside the socket. And lateral luxation, it would move laterally. It would become lodged in either of the wall, mesial, distal, buccal, or the lingual wall of the socket. So looking at the condition over here, you can make out that the incisal edge of this tooth is here and this tooth is slightly up, so it is intrusive luxation. Answer to this question would be C. You can see there is a subtle difference in the occlusal plane of the two teeth. Okay. So move over to the next question. Which is not a regenerative endodontic procedure? Regenerative endodontic procedures, they are basically related to biologically based procedures for non-vital immature teeth. Apexogenesis, postnatal stem cells, pulp implantation, or revascularization via blood clot. If we look at the options, apexogenesis is a vital pulp therapy result. It is a result of vital pulp therapy. Whenever the radicular pulp is intact and we do procedures like pulpotomy, there is continued root development. Okay, so which is a part of a vital pulp therapy procedure, that is apexogenesis. If we talk about regenerative endodontic procedures, then these are used for non-vital pulpless teeth. So whenever there is a non-vital pulpless teeth, we have to employ some sort of stem cells. So the option B is correct. Postnatal stem cells are involved in this. Pulp implantation. Pulp implantation basically means that in a non-vital tooth which is pulpless, because of your revascularization or regeneration procedures, there is development of some pulpal tissues. And revascularization via blood clot definitely is one of the most common thing we do. We induce periapical bleeding in a non-vital open apex tooth. So whenever the blood seeps inside the root canal, it carries along some stem cells from the apical papilla. Okay, there is an immature pulpless tooth, we induce bleeding, the blood seeps inside the root canal. So definitely this also involves regenerative endodontic procedures. So I would say B, C and D are part of REPs, and apexogenesis is a part of your vital pulp therapy, which results in continued root development. So answer to this question would be A. It is not a regenerative endodontic procedure. See, apexogenesis may be the result of pulp regenerative, but it is not a procedure. Coming over to the next question. The post-endo pain is best managed by codeine, ibuprofen, tramadol, or acetaminophen. Post-endo pain means pain associated with reversible or irreversible pulpitis, mostly irreversible pulpitis, symptomatic irreversible pulpitis. Now, to assess the efficacy of these different analgesics with respect to endodontic pain, a large study was conducted that was called League study. Okay, this League study found that the anesthetic efficacy of the drugs like acetaminophen, ketorolac, and ibuprofen these three drugs, all these are non-steroidal anti-inflammatory drugs, is superior as compared to other non-steroidal anti-inflammatory drugs. So if we look at the options, definitely codeine is a opioid type of drug, it is ruled out. Tramadol is ruled out because the most effective drugs are non-steroidal anti-inflammatory drugs. So we are left with options brufen and acetaminophen. Answer could be either B or D. This study also found that ibuprofen in high doses of 600 to 800 milligrams for 3 times a day is the most effective drug in curbing the pain associated with endodontic pathologies. So the option B is definitely given choice over acetaminophen. B would be the answer here. Coming over to the next question. The most unique property of MTA is unique property of mineral trioxide aggregate they are asking. It sets in 2 to 3 hours. It sets in moist environment. It is biocompatible and it contains calcium. The most unique property of MTA is that it is a highly biocompatible material. Although it has a highly alkaline pH of 12.5, which is the same as that of calcium hydroxide. If we make a comparison of MTA with calcium hydroxide, they have the same pH of 12.5. But calcium hydroxide, when placed in contact with vital tissues like vital pulp, induces necrosis of the vital tissues. So it is not biocompatible. On the other hand, MTA, which has a very high alkaline pH, when placed in contact with the vital tissues like dental pulp, do not produce any type of tissue damage or necrosis. It is highly biocompatible. So the answer to this question would be C. It is one of the most unique properties of MTA. Coming over to the next question. The coronal flaring serves all of the following purpose except coronal flaring means it is talking about some cleaning and shaping procedure. We flare the coronal 1/3 of the root canal. It removes reparative dentine from around the canal orifice. It allows files to have unimpeded access to the apical 1/3. It gives early access to disinfecting irrigating solutions, and it is useful in assessing canal morphology, curvature and ledges. So if we look at the technical aspects, then options B, C and D, they are justified, that whenever we do the coronal flaring of the root canal, the file is able to reach to the depth of the root canal unimpeded. Whatever irrigants and medicaments we place have a better access to the apical third of the canal. And definitely when the coronal orifice is wide, the coronal 1/3 of the canal is wide, we can, using microscope and all illumination, it helps in assessing the canal morphology, curvature and ledges better as compared to a non-prepared preparation. So answer to this question would be option A, that is not the purpose of removing the reparative dentine from around the canal orifice. Moving over to the next question. What should be done to reduce the chances of sodium hypochlorite accident? To answer this, you should basically know what is sodium hypochlorite accident. Sodium hypochlorite accident is a technical term that is used to describe the periapical extrusion of sodium hypochlorite. Now, sodium hypochlorite is a very toxic chemical. If it goes into the periapical tissues, it would cause rapid hemolysis, ulceration and necrosis of the tissues. So it has to be avoided. Now the question is asking what should be done to reduce the chances of periapical extrusion of sodium hypochlorite. The concentration of the solution should be adjusted to 5.2. It is of no relevance to prevent the extrusion. It should be mixed with distilled water only. It should be mixed with saline only, or we should access the backflow in the initial irrigation and keep monitoring subsequently. So it is basically not about the solution. It is not about the concentration of the solution. It is not about the mixing of solution with saline or water. It is always about the clinical technique. Whenever we do syringe irrigation, the syringe should be passively fitting inside the root canal. We should have a loose syringe or needle inside the root canal. So we should always access backflow in the initial irrigation and keep monitoring continuously. Means whenever we flush out, there should be adequate space for the backflow of sodium hypochlorite from the canal so that it is not extruded periapically. So answer to this question would be option D. So what is the most important thing? We have to do passive flushing or irrigation of the root canal with a loosely fitting needle inside the root canal. Moving over to the next question. In endodontic surgery, while using microscope, that is microendodontic surgery, what is the magnification used for root and amputation? Root and resection or amputation? See, whenever we use dental operating microscope, there are three range of magnifications available: low, medium and high. Low magnification is 4 to 8x. Medium magnification is 8 to 14x, and high magnification is 14 to 20x or maybe higher. So whenever we are doing a surgical procedure like root and amputation, then majority of the procedures are done in medium magnifications. The low magnification is used for the initial orientation with the working area, and a high magnification is used to understand the finer anatomical details like presence of cracks, fissures, presence of isthmus. So whatever anatomical details we have to examine are done with high magnification, but procedures, whether it is root and resection or preparation of the root end, all would be done in medium magnification. So with that background, if we look at the options, very low range magnification, low range, medium range or high range, answer would be option C. They are used in mid-range magnification of 8 to 14x. Okay, moving over to the next question. The time in which the osseous defect is filled with bone tissue following periradicular surgery. Most of the time we do periradicular surgery whenever there is a resorptive defect in the periapical bone. So it is asking what is the time in which an osseous defect is filled with bone tissue following periradicular surgery. So osseous defect, it is asking, is the surgical defect that is created after curettage of the periapical pathology. 10 weeks, 12 weeks, 14 or 16 weeks. What is the time frame required? See, mostly it happens in 14 to 16 weeks duration. Okay. Now if you look at the options, both are there as options, 14 week and 16 weeks also. And when both are there, we have to make a choice between one. We go with the higher, that is 16 weeks. So option D would be the answer over here. This is something you have to learn, you have to remember. Okay, so this much is the time that is required. 16 weeks comes to 4 months roughly. Okay, so you can get the options in months or in weeks. Moving over to the next question. The best time for the shade selection with 5500 Kelvin light is, it is asking you about shade selection and matching. See, shade selection is always done in northern daylight. Northern daylight. Okay, a daylight that is subtle enough not to produce any glare or something, so directly not in the sun, but northern daylight is best considered for the shade matching. Now it is asking you about the time, whether 9 to 12 p.m., 9 to 1 p.m., 10 to 2 p.m. or 10 to 12 p.m. If you look at the time frames, then definitely the daytime 9 to 1 p.m., this is considered to be morning. Okay, this is morning to noon, late noon. So the best time, suitable time would be 9 to 1 p.m. Option B would be the answer here. Moving over to the next question. ICCMS protocol is for caries management, disposal of PPE kit, COVID-19 patient treatment, or method for decreasing aerosol dispersion. ICCMS is basically a part of International Caries Detection and Assessment System. Okay, so it is caries control measurement system, and which is definitely used for caries management. Okay, it is International Caries Management System related to the United States International Caries Detection and Assessment System. There are some visual scores. Visual scores are 0, 1, 2, 3, 4, 5 and 6. 0 to 6 visual. 0 through 6 are the scores given, and these scores basically indicate the severity of caries from minimum to the maximum. So definitely this is used for caries management. Answer to this question would be A. Moving over to the next question. Which of the following can be used for drying the dentine following cavity preparation? Acetone solution, alcohol solution, air dry desiccation under high pressure, or cotton pallet with water and light bursts of air. It is asking you about dentine. Dentine is an inherently moist tissue because of the presence of dentinal tubular fluid. So whenever there is forceful excessive drying of the dentine, what would happen? There would be fluid movement from the dentinal tubules that would lead to stimulation of A delta nerve fibers due to aspiration of odontoblasts. Okay, so that has to be avoided. We have to always do gentle drying. So acetone and alcohol solutions, they are strong desiccants. Air dry desiccation under high pressure again would lead to aspiration of odontoblastic nuclei into the tubules. So the best method is a moist cotton pallet is used to gently dry the dentine, which prevents the dentinal tubular fluid movement. Okay, so option D would be the answer over here. Please remember that do not get confused. I could see some of you getting confused with acetone or alcohol. See, acetone or alcohol are non-aqueous solvents. They evaporate. When they would evaporate, they would definitely pull out the dentinal tubular fluid with them. So a cotton pallet with light bursts of air, moist cotton pallet, which indicates cotton pallet with water, and light bursts of air should be used. I hope it is clear with everyone. Now we talk about the next question. Again, a figure based question. The correct sequence of canal preparation in step back technique is what? Now, a step back technique basically means we do the apical preparation first, then the middle 1/3, and then the coronal. So the sequence is we step back from the apex. So definitely we do the preparation in this aspect. The apical, middle, and the coronal 1/3. So a straightforward question is there. What would be the sequence? 1, 2, and 3. That is C. Moving over to the next question, which is also based upon a canal cleaning and shaping technique. The chances of canal blockage are minimum with balance force technique, step back with reaming motion, step back with circumferential filing, or crown down pressureless technique. The chances of canal blockage are minimum with. See, whenever we use balanced force technique, we use only rotary motion. Only rotary motion is used. No pulling and rasping of the file is done. Only clockwise, anti-clockwise turn is done. Step back with reaming motion. What is reaming motion? It is penetration into the root canal, rotation and retraction from the root canals. Step back with circumferential filing. Whenever we do circumferential filing, we do filing of all the walls of the root canal. This is known as circumferential filing. Or crown down pressureless technique. Crown down means we start from the top of the root canal, go down, go down, go down without involving any form of pressure. So the chances of canal blockage are minimum with. Canal blockage occurs due to packing of dentinal debris. Isn't it? Whatever debris is generated due to cutting of the root canal, it is packed in front of the file. So whenever some sort of pressure is applied on the file, there are chances of canal blockage. In balanced force technique, although it uses rotary technique, there is apical force during counterclockwise turn. In reaming motion also, there is penetration and force. In circumferential filing also, there is up down against all the walls. So all these have a chance of canal blockage, and it is minimum with crown down pressureless technique. Option D would be the answer here. Okay. Moving over to the next question. Identify the root canal preparation error shown in the image. Is it apical zip formation, ledge formation, apical zip with perforation, or ledge with perforation? You can see this is the original apical foramen and it has been transported over here. So definitely it is not ledge formation. We rule out the options B and D. There is no blockage of the root canal. But there has been transportation of the apical foramen to a new location which is mostly located on the outside of the curvature. So this is definitely zipping of the root canal and apical zip formation with perforation, because you can see there is communication with the PDL. So answer to this question would be option C. If the figure was like this, okay, and like this, then it is only apical zip formation without perforation. Now this is apical zip formation with perforation because there is communication established with the PDL around the tooth. Answer to this question is option C. Okay. Perforation means a artificial connection is established. Iatrogenic connection is established between the root canal and the PDL apart from the naturally existing apical foramen, etc. A ledge formation means ledge. Ledge is a horizontal shelf or blockage in the root canal. Okay, this like this is known as ledge. Ledge formation means a horizontal extension. Ledge, what is a ledge? Ledge is an extension. So from one wall of the root canal there is a horizontal extension which is preventing the access to the apical extent of the root canal. Moving over to the next question. Now this type of question is another true-false type of questions being asked, where they give you a statement and they give you a assertion or reasoning for this. So the statement 1 in the present question says that the pulpotomy can be used as an emergency treatment for symptomatic irreversible pulpitis. Pulpotomy. Okay. Statement B says antibiotics is mandatory emergency treatment for symptomatic irreversible pulpitis. Whenever there is symptomatic irreversible pulpitis, the patient is in severe pain, and if there is it is considered to be endodontic emergency. And when the patient sees the dentist and there is out of the turn appointment, we cannot treat the patient. We have to manage the pain of the patient. So as an emergency treatment, we remove the pulp so that the patient is relieved of the pain. We do not clean and shape the root canal. We simply do pulpectomy, etc. Okay, but here it is written pulpotomy can be used as an emergency treatment. So I think there is some mistake in the typing of this question. It should be pulpectomy. Pulpotomy is partial removal of the pulp, but partial removal of the pulp would not help the patient who is having symptomatic irreversible pulpitis because the complete pulp is necrotic. So you have to basically understand the difference between pulpotomy and pulpectomy. Pulpectomy is complete removal of the pulp. So to alleviate the patient's pain, we have to do ideally pulpectomy. But there may be some we can accept pulpotomy as a treatment. And antibiotics is mandatory? No. So statement A is true and the statement B is false is the best possible answer to this question. Okay. Moving over to the next question. Berodontalgia would result in sharp pain on ascent. Ascent means we move up, there is increase in the altitude. From the ground level we are moving up. In cases of irreversible pulpitis, reversible, normal or necrotic pulp. Berodontalgia means whenever there is low atmospheric pressure due to high altitude. Okay. See, whenever there is inflammation of the pulpal pressure is increased. The pulp is trying to push, and whenever there is atmospheric pressure, the atmospheric pressure is trying to oppose the pulpal pressure. But as the person moves on higher altitude, the atmospheric pressure reduces, or I would say the pressure which is opposing the pulpal pressure is reducing, so the patient feels more throbbing and pain from inside of the tooth. So this happens mostly in cases of irreversible pulpitis. A tooth with necrotic pulp would not clearly demonstrate berodontalgia or difference from pressure. It is mostly irreversible pulpitis. Option A shall be the answer over here. Okay. Necrotic pulp usually do not typically show berodontalgia. Berodontalgia means due to change in pressure. Low atmospheric pressure, high pulpal pressure is berodontalgia. Irreversible pulpitis is a better option. Please do not be confused with necrotic pulp. Now this is something related to endodontic surgeries. Considered safe is INR is. INR is International Normalized Ratio. Instead of the prothrombin time, we measure the coagulation cascade by INR, and ideally it should be less than 2 in a normal pulp. But it is considered safe when it is up to 3.5 to 4.5, so we stick to option A. Okay. You can read more about the international normalized ratio from your textbooks. but normally it should be below 1, 2 for normal people. Moving over to the next question. To bypass a ledge, now you know what is a ledge. Ledge is a horizontal shelf-like extension that blocks the canal and prevents the access to the apical 1/3 of the root canal. Which of the following should be done to a size number 8 or number 10 file, the small file? Bend apical 1 to 2 mm, forming 30-degree angle with a shaft of the instrument. Bend apical 3 to 4 mm, forming 30-degree angle with the shaft of the instrument. Bend apical 1 to 2 mm, forming 45 degrees angle, or bend apical 3 to 4 mm, forming 45-degree angle with the shaft of the instrument. Now this is basically related to technique for bypassing a ledge. So if suppose this is an endodontic file, a straight file, and I would bend the apical 1/3 of the file like this to bypass the ledge. The range of bending is usually 30 to 45 degrees. Okay, a 45-degree angle is more acute and it is considered more effective in bypassing the ledge. More acute angle, okay, it helps in negotiating the canals better, looking for this. So apical 3 to 4 mm with a 45 degrees angle of the shaft of the instrument is best option here. So answer to this question would be option D. Moving over to the next question. An 8-year-old patient presents with trauma history. The treatment is initiated by dental surgeon as shown in the radiograph below. Identify the treatment modality that the dentist has used. Looking at the photograph, you can clearly identify what is the treatment done over here. It is an apical plug of a radiopaque material that is being formed, and this apical plug of radiopaque material is formed in the procedure of epexification, forming apical calcified barrier. So the option is apexogenesis, root canal treatment, empty epexification, or calcium hydroxide epexification. Now there are two options, but you can see it is such a uniform dense apical plug, which is not possible with calcium hydroxide. Calcium hydroxide forms an apical plug which is not very uniform. It is not very dense because of the porosity present. So this is an empty epexification. A uniformly dense radiopaque plug is formed which is sharply demarcated on the radiograph, indicates some radiopaque calcium silicate based material like MTA has been used and not calcium hydroxide. So answer would be option C, MTA epexification and not calcium hydroxide epexification. So this is all about the today's session. It is just to demonstrate how the questions are being asked in your INICET examinations, what are the patterns. So you could see that majority of the questions were based on images and they were relatively straightforward, no twisting etc. was given. So if you master the subject, understands the basic, you would be able to solve the MCQs very well. So please keep connected for the future updates. We would be in constant touch about all these things, and my best wishes for the forthcoming examinations. I hope it was a fruitful session for you. Thank you so much everyone.